morning, everyone. It's 9 o'clock, so we'll go ahead and get started. I guess 8 o'clock for some of you over in the West, so thank you so much for joining us, whatever time it is where you are. My name is Sandra Seibel. I am the change lead for the Bridge Northwest program or the Meditech Expanse program that we are just kicking off this month. And so we're very happy today to have our partners and colleagues from the Northeast through the One HITS, the One Health Information Technology Service Group, who have, spearheaded or run the implementation in 23 hospitals in the Northeast over the last several years, and are going to be really guiding and helping us with the implementation of their wave 3, our sort of wave 1, I guess, of getting things online for Expanse. So this is the third of 3 demos this week. We've had some excellent questions from everyone who attended and some really great functionality that we've seen from the system. So I'm very pleased to hand it over to Maria Watling, and thank you very much.
Thank you, Sandra, and good morning, everyone, and welcome to our demo this morning. I'm Maria Watling, the Clinical Build Manager for One HITS, and we're excited to have you with us today. Today we have the team back, Sherry Rogers, Catherine Brazeau, Erin Zapshala, and Krista Jablonski, demonstrating how Meditech Expanse is used in the inpatient setting to support patient care. A reminder that this session is being recorded, and to keep the session running smoothly, we kindly ask that you type your questions into the chat throughout the demo, and the project team will address them as we go. There will also be a Q&A session at the end of the demo. And with that, I'll hand it over to you, Sherry.
Thank you, Maria. Good morning, everybody. This morning, I'm going to play the role of the physician. I'm going to steal the share. I am once again. My patient, Granny Smith, has been in the ED department for a number of hours. She came in with shortness of breath. I can see my triage note. So a little review from yesterday with the ED tracker. I can see she's in exams. She's hearing impaired. She has shortness of breath. The triage note for my nurse is viewable with this little pink tab here. I've already started a draft document on my patient. She's been here for a while. I can see her recent set of vitals that has been taken, imaging and labs that have been done. And as I said yesterday, if it's highlighted green, there's a result. I've already looked at my imaging, so it's now grayed out. And any orders that have been placed that haven't had action on them yet are in white. This is actually a scrolly section. So if there was more orders, as you see of the patient above Granny Smith, I can scroll back and forth on previous things that have been on that patient. If they have a number of orders, you can scroll back and forth. So this morning, we're going to actually admit Granny Smith. And I'm going to start by going to my draft note to display what I have done in addition to the notes that I reviewed yesterday. So I'll just do a little brief review. Again, I'm using the ED adult note with the asterisks. So that has all the additional sections for the past medical history, the allergies and meds, the vital signs and exam section, the medical decision making. All of those extra sections are in this particular note. As I said, we have copies of notes that are just a narrative box because a lot of physicians prefer the narrative box. So the vital signs and triage note, sorry. Are we good? Okay. The triage note and vital signs default into this template. That's been set up on the infrastructure of the actual note type. We can do that with a lot of physicians' notes and embed some of the nursing details into it. Physicians can also bring in formatted data. So if I go back to my narrative section and this A here, I have an opportunity. If I have quick text and I've created my own little short notes, I could use that. If there's some canned text available, which is like a defaulted template of information, I could use that. And formatted data is things I can grab out of the chart. So I could add to my note using those methods. In this particular note, I chose to go to the assessment and plan section. I chose a problem specific. So on my patient's reference panel on the right-hand side, you can see my patient's problems are pneumonia, hypertension, and an upper respiratory infection. So I've chosen the pneumonia, and I've chosen to put a problem-specific plan in for my patient. So I'm going to admit this patient. I've decided today that she needs admission. She's not doing so well. Her x-ray shows a right lower lobe pneumonia, and I'm going to admit her to the hospital. She's already started on an IV antibiotic. I'm going to send a sputum her culture, and I'm going to get some assistance for her at home. So I've updated my note. I'm satisfied with this. I wouldn't be doing a discharge because she is going to be admitted. So I'm going to sign my note. It does come up and say, hey, you have an unanswered documentation because I put something in. So I'm just going to save it for now. When you use the problem specific plan, that's what happens. If you use just the generic consolidated plan, it wouldn't force me into that situation. I'm going to go to orders because I want to place orders on my patient. I can see the red reconcile button. That means that my patient's had her best possible medication history done. And if I look on the right sided panel again, there is a section for home medications, and I can see she has an active order for nitrofurantoin. So I can reconcile that if I want the patient to stay on it. Or I could put it on hold. So if I want that to continue on my patient, I can select that from here. I can say it was last taken April 15th, which I'm sure is just old. It was used for the UTI that she previously had. So maybe I'm going to place that one on hold. And I'm going to submit that. Again, the 4-digit PIN that all physicians use for their orders. So I've placed that. So now I've dealt with my home medication. So you can see my red reconcile now disappears. I'm going to go to the transfer and admit routine. So I'm going to hit transfer admit. And I'm going to transfer my patient to one of the floors in North Bay. Erin, I believe we're doing C3.
Yeah, that's correct, Sure.
Thanks. So you can see when I go into the transfer and admit routine that I first get my transfer order. So this order is telling the clerk where we're putting this patient, where I want my bed to go. This is site specific. So you can see the list was North Bay's list. Every site would have all of their locations in that transfer to location, as well as the transfer from location. So this is used on the floors as well when you're transferring patients from unit to unit. All of the orders that were currently in Emerge exist on this patient, and I get to make decision on each of them. They do come in with a continued all, and that's for ease of use for our physicians, and that's by choice. The physicians were given a decision whether they wanted to come in with a stop all or whether they wanted to come in with a continue all, and they felt it was easier to continue all, and they would just stop the orders that they didn't want to continue out of Emerge. So you can see this goes by section. So cardiology services for the ECG. If it hasn't been done, it will continue. The best possible medical history. I know that's done, but it's going to continue. Oxygen, isolation, because my patient's already on isolation. So that's going to continue. And then my meds show at the bottom. So visit meds and home meds do come in together. So you can see I have a home medication on hold here. If I continued that, you would see a little sign in between where it's linked to a visit medication. So that home medication transitions into a visit medication. And if I decided, oh, maybe she only has one dose of that left, I'm not going to continue it now. I can now change my hold and continue that medication instead. Now you can see that little link is there, and it's asking me when I want the first dose to be. Okay. And I can see that Emerge has already started a normal saline IV going on my patient, and I'm happy with that. So in order to admit my patient, I need to add new orders for the inpatient unit. So I'm going to go to add new. This brings me to the order catalog. Again, my favorites display first because that's what I have. Order sets are available to physicians as well, and I could switch here and go to sets, and then it'll present all the sets to me. It will take quite some time because the catalog is lengthy. And now I regret doing that because it is lengthy, and in test it takes a long time. Oh, Sherry, what have you done? Oh, I'm so sorry. There we go. Okay. So just like in an emergency yesterday, I do get suggested sets because she's still in an emergency. It's going to show me that shortness of breath set automatically. You can see they start alphabetically. If I wanted to find my pneumonia set, I would just type in pneumonia, and it'll condense down to anything that starts with pneumonia. Now, remember, I said that it does do a search by keyword, so you can see other orders here that don't necessarily start with pneumonia. Okay, I'm going to choose this admit pneumonia set. You can see there's a community acquired, there's a hospital acquired, and there's a suspected aspiration as well as a ventilator associated. So we do have a number of sets. The icons at the side give you an indication on what I'm looking at. So the ones with the pencil is a single orderable. The ones with the folder is an admission set or an order set. And because there's two little folders, it has suggested sets attached to it. So I might have the pneumonia set, and it might also suggest a sleep management set and possibly a nicotine replacement set. One that has a single folder that has no associated suggested sets attached to it. An RX shows me that there is a medication string only. So I'm going to pick the admit pneumonia set on my patient, and that's going to preload in. I have a number of pre-selected orders and some required fields that I'll need to fill out in order to get my patient's orders completed. I'm going to admit under the attending provider of Dr. McKenna. My patient's already on droplet. You can see that here. That came from nursing. And my admission diagnosis is already filled out as pneumonia for me. I have to fill in all of the other fields if they're a required field. My resuscitation status, my diet comes in already pre-populated if I need to change something about that or add something to it, or I could deselect it and drop the arrow and it would show me other diets. So if I wanted to choose a different diet on my patient, I could choose that I want to start low sodium on this patient. I'll continue down. The order sets have a structure that is standardized, as in the sections flow the same in every set. So admission at the top, then diets, then activity restrictions, respiratory, patient care, IV solutions and medications, labs, DI, consults, and allied health. So that structure is based on every set, so that our physicians will be used to seeing the same structure and know where to anticipate their meds to be. I can see that my oxygen saturations if below 92%, even though I have it as an orderable, it's already ordered, so I don't need to select that again. It's continuing because I continued it in the orders. You can see the patient had multiple orders for IVs. It would only get one, but she does have an IV going. So I'm going to pick a few other medications. I'm going to pick some Ventolin. I can go down. I can open out this non-opioid set, even though she has a Tylenol. Maybe I choose to give her ibuprofen on top of that because she has fever. Continue down. We're going to give her VTE prophylaxis, of course. And maybe I want some labs for tomorrow. So I'm going to pick a CBC for tomorrow. And you can see this says AM lab draw, so it's going to start tomorrow morning. Do a couple of those. I did say that I wanted a sputum culture in my note, so I'm going to make sure that I click that. I don't think we need a daily chest x-ray, but maybe I want another one, but I want it 2 days from now just to see whether we're resolving. Okay, and I said that I wanted to see social work. The one I haven't addressed yet, barriers to return, is her ceftriaxone. So I need to go back up to the section where her antibiotics flow in, and I need to find my ceftriaxone. And so I'm going to order that. And because I still have this flag at the top that tells me there's a next required field, I'm going to go search out to see what that is. I have a relevant history. Oh, and I can't spell this one. There we go. Okay. And I'll click that again to make sure there's no more. That disappears once I've hit my required field. So all my required fields on all of my orders have been filled out. And if I submit, there is a first dose warning on orders. That will become because I've chosen some meds and they want to know, do I want to give it now or would I like to start tomorrow? I can review those from here. So the nitrofurantoin, I'm going to say she didn't get it today, so I'm going to start it today. Then the dalteparin, I want it to start today. And the ceftriaxone, she's already had her dose and emerged, so I'm going to save that for tomorrow. It always does a recheck on your resuscitation status, and it will do that anytime you edit a resuscitation status as ordered as well. So it always asks you, it is now set to full resuscitation. Do you wish to continue it at that? And so I say yes. And that is a double check that always happens. And then I sign my PIN orders. And you can see now that my patient has a little yellow flag on their orders. That little yellow flag means that there's transfer orders on the patient. In emergency room, if I had something that I wanted to be given only while she's in emerge, I could enter another order here and it would only take place in emerge. But if I want something to order and continue, I need to go back into those transfer orders and add my order there so that it will continue from today going forward. And then my patient.
My trackers that I showed yesterday. So I'm just going to move this one little screen over here. So here's my patient. I'm working off my My List. So my My List is going to show me all patients that are assigned to me, but I could work off other trackers. Looking at my patient, I can see I've got this yellow tran under the transfer orders / discharge column. So this is my flag that I've got some admission orders to review. So I can click into this field and it's going to launch me into the orders routine. I can click into transfer to pick who the provider is. And then I can review what Dr. Rogers has ordered. Typically, we will wait to process these orders. These orders are kind of like in a limbo status right now until I process them. Typically, we like to wait until the account is rolled, but as the emerge nurse, I want to quickly scan to make sure there's nothing I should do now. So say the ceftriaxone was due today, and maybe right now Sherry started it tomorrow, but this is one I could place a check mark here to process now and have it flow to my MAR. But right now I'm satisfied with what I'm seeing. It can wait until this account's rolled. I would do my documentation, anything like that. So at this point, I'll turn it over to Kat to do the registration piece, but I'm just going to talk a little bit about workflow. Who processes the admission does vary widely across the one-member sites. Some larger sites have 24-hour bed allocation that are doing this job. Some sites have clerical staff for certain hours of the day or 24 hours that do this work. And in the small sites, the ED nurse is also the inpatient nurse, is also the registration clerk, is also bed allocations. So to kind of accommodate some of these workflows, we do have a tracker. So remember yesterday I said we have trackers that can slice our patients in view by different events. So we do have something called an admit request tracker. So once the physician enters in that emerge order, clerical staff will be flagged that there's an admission to process. So I've got a red flag telling me that there's a new admission. I could click into this field to be brought to orders where I can actually review the actual admission order. So here's that admission order. I could look at the detail to see Dr. McKenna is going to be the attending provider. I see the admit diagnosis is pneumonia and this patient's going to medicine. Once I complete my account update, this patient would fall off this tracker. And I can quickly see I've got 2 patients on this tracker. These numbers up here beside the title reflect how many patients are on each tracker. So I'm going to stop sharing and I'll turn it over to Kat.
Thanks, Erin. I'll share my screen now. Okay. Can you see my tracker?
Yeah.
All right. Yeah. So I'm going to play the role of the ED admitting clerk. The emergency department or admitting clerks are provided access to the ED status board, a valuable tool for rolling over an ED account into an inpatient account. We'll be rolling over the ED account to an ED overflow account. Some facilities use this process to continue documenting an ED while waiting for an open bed. Utilizing the status board helps minimize the risk of selecting incorrect accounts. Additionally, this approach reduces the need to switch between 2 different modules, being Reg and ED, and this streamlines the process for greater efficiency. So the work lists are access driven and dependent on access. The assorted tabs can be automatically defaulted or manually selected by using this little drop down caret here. So as Erin was explaining earlier, we could look for the admit request, or you could leave it in the all patients, depending on the workflow. We could also look for the patient by clicking in the Find Patient field up here. So I am going to look up the patient by the account number, just to show you that it can be done different ways. And then I would add this patient to my list. And then when I go to my list, it'll populate down here. Now, I'll place a check mark in the appropriate box beside the patient's name. It will open up and give you more information here. You can see the account number and all the MRN, health card number, so on and so forth. Any information. So depending on where you click, you can do different things on this list. Now, I'll go to the little hamburger button up on the left-hand corner here. This is what we call it, or it's the menu button. And if you click on that, you could select the admit as inpatient. At this point here, you would select your registration type, and I'm going to select inpatient. This will now bring you to the inpatient registration questionnaire. At this point, I'll follow the script for registration and verify and fill out any appropriate fields, including the custom queries. So I will just go from tab to tab and make sure that all the information is filled out. If there's any custom queries, like the patient experience survey, you would fill this out. Contacts, guarantor, insurance, provider tab. Oh, yeah, it doesn't matter. The attending provider. This is also, do you consent to automatic reports from this visit be sent to your family provider listed here? That is also a custom query. And this can be tailored to the facility. Now the visit, the admit category, and the admission sources, I will fill those out. This is admission sources by emergency room. Anything that has an asterisk beside it is mandatory. And if you miss anything, when you click save, the system will prompt you to tell you that there's fields that have been missed, and it will actually bring you directly to those fields. So I'm going to look for medicine for the service and the room preference. I'm just going to put ward for now. Now the room, you can do a search or you can type it in. I'm going to choose the emergency inpatient overflow. And then you would select an open bed. Anything that doesn't have, if there's a number beside it, these are open beds. So I'll plunk the patient in here. This is going to give me a conflict because of the service, but that's okay for now because it's in the test system. So there's a last hospitalization down here. I'm just going to put something in here. So, and then you'll notice that there's a miscellaneous tab and all kinds of other tabs that are, they can be associated to clinical, not really filled out by registration, but it pulls in information. So I'm just going to fill in the required field here. It's asking me if the tobacco has been used within the last 6 months. So like I said, the other tabs could be pharmacy driven or clinically driven, and that will pull in queries from clinical side and not necessarily filled out by reg. So once we satisfy all the fields, we would click save. At this point, it's giving me the new account, which is NI 4526, and that's just telling me that the patient is now an inpatient, and the medical record number. If there's any forms or armbands that need to be printed, you would select these now and how many copies and send it to what printer. I'm just going to cancel it for now. Okay.
Okay, I can start sharing my screen again. Okay, so back to ED nurse. Share. And I'm just going to refresh my screen. So you'll see that now my patient's registration status has updated to admitted inpatient because Kat completed that admission.
Erin, we've got your VM Horizon client. We just need to see your screen.
Okay, 1 second. Thank you. I'm just trying to see where I can reshare.
You're good.
Okay. So my registration status is updated to admitted inpatient because CAP rolled that account. That ED status event has automatically updated to flag me that my patient's now admitted. I have, if I open up my detail box, I can see that my account number now has been updated. So now, as the emergers, I'm going to go ahead and process these transfer orders. So I'm going to click into here, hit to transfer, and I'm going to select process transfer at the top. And it's going to just flag me, are you sure you want to process these admission orders? And I'm going to say yes. And so once I process this transfer orders, it takes them out of that pending status. Medications will now flow to my MAR. Any lab tests will now, go to the lab module. Any of those nursing orders will now flow to my work list. And that transfer order flag now disappears. So the other thing I just want to talk about, depending on workflow, we do have some admitting departments that have ED trackers, and they're actually utilizing the status events to flag nursing when beds become available. So this patient here, it says bed assigned, not ready. So I know as the nurse, I've got a bed coming down the future. Admitting can set no bed admission, flag you that your patient's now staying the night and emerge. But we'll say that this patient has a bed, they're going up to C3, it's a great day in the hospital. So at this point, TOA kind of varies site to site. So I'll just kind of do North Bay's process since we're using North Bay. What I would do as the emerge nurse is, I know this patient's going to C3, I would call C3 and ask to speak to the nurse who's getting Granny Smith. I would go ahead and that's gonna be Krista. I'm gonna give Krista a verbal report on the patient. How I record my report is I'm gonna select my patient here, and I've got a shortcut button here that says open handoff. I'm gonna click off that. If I'm giving Krista a verbal report, I've got some widgets here that I can tailor this to my needs, but these are the standard widgets just to help flag me with my report, so I can tell Krista the triage summary. I'd be able to rhyme off this visit's lab tests, maybe my last set of vitals, ins and outs, current meds, and I can write a note covering what I have communicated with Krista. So let's just say I reported pressure under 100. Maybe I, let Dr. Rogers know that blood pressure is a bit soft. I'll cover my butt that I have, told the inpatient nurse that I'm aware of this. I'm going to click save. Because I'm writing a note, I have to enter my PIN number. And it's going to save to the chart. And at this point, I would book my porter, get my patient upstairs. So the other thing that I need to do now as the emerge nurse is I have to discharge them from the emergency room. And I'm going to do that the same way I discharged my patient yesterday. And it almost seems counterintuitive that you're discharging your patient, but you're just essentially telling the system they've left the emergency department. So it's the same discharge plan from yesterday. I still have to do that ED discharge assessment. So this time I would say that they're admitted to an inpatient unit. Again, I can say I'm discharging them, and maybe they went up with a stretcher and a porter sent them up. Patient disposition, so those still look to those NACRS disposition codes. So I'm going to select admit to another unit. And then I now, because I've satisfied all the discharge requirements, I can say the discharge date and time is today. The system's smart enough to recognize that because this account has been rolled to an inpatient account, me applying this discharge date and time does not discharge their hospital visit. It's only closing that ED account. So I'm going to say today and now. And I'm going to say yes, and I'm going to hit save and close. And you'll notice now, this patient would fall off all my regular ED trackers. They would go to the discharge tracker. This is my list, so patients will stay on here for about 12 hours after a final event. But you'll notice that my patient status, instead of saying discharge like that ED patient yesterday, my patient status is now left department. So at this point, I'll hand it over to Krista, and she's going to play the part of the inpatient nurse.
Hi there. And I'm just going to share my screen. Okay, so I'm the floor nurse, and normally bed allocation transfers the patient to the inpatient floor once left. So if this was my unit, I would go and find the patient after talking to the emerge nurse about the transfer or the admission. So I'm searching up in the right-hand corner, just your patient account number. There we go. So I can see that's Granny Smith, birth date, account number, I'm confirming with today's date and the location. So I can either add to my list or add to my list and go to chart. Normally the first thing is you kind of add it to your list so it's set there and you can go back to it and have a quick look at the chart. We went through this the other day. So it's just kind of looking at the highlight. So I talked to Erin, the emerge nurse, and I want to have a quick look at her handover. So I will, here we go. And then when I open handover, I can have a look of what she said and kind of review, especially if I didn't write it down when she called or talked to her. So just looking at this, review everything like that. So next we'll go to document. So as long as your patient is selected here, you can hit the document button. As you can see, there are orders that transferred over from the emerge and the admission orders. I want to add a standard of care because I'm on the medicine unit. I want a standard of care that respects that unit. So if you write standard of care here at the top and search for medicine, you can see that medicine standard of care comes up. If you look at the information, it gives you a quick overview. Let's say you're trying to figure out if this is a medicine or any surgical mental health patient, you can actually see your interventions before you select. You can go return to lookup, change it up if you like. If you like it, just make sure that the one is selected and hit save. Now it's saying that I have a care plan items which have resulted in duplicate interventions. Because this patient came from emerge, there may be some duplicates. When you look at your duplicates, I'd like to review them. So anything not attached to my standard of care, I want to just say complete. So yes, they did a TOA and emerge, and a TOA, or sorry, and an IV line assessment. So I'm just completing these because I want to stick to my standard of care and make sure that there's no duplicate interventions on my list. So there, and then you hit back and your standard of care loads, which looks a little similar as far as your interventions on your current PCS. So when I first started admission, you can see that there are clocks. So as you can see, there's a now column, as well as when it was transferred over. So at 8:41, a BPMH order was done, so that would have been emerge. There's a collect specimen here, and then today at 9:38 is when the transfer occurred, and the clocks are available. So, for example, I came to all the assessments. You would do your admission assessment general. One thing I can concentrate on are the physical assessments. So a nice way to organize is if you go to A to Z, or if you're a backwards W to A person, you can organize it by that. You can also organize it by intervention or assessment. So anything with an A beside it is an assessment. The little O beside that means it came from an order. So this social work came from an order routine. Same with the I did it. So it's just letting you know an I as an I did it. So it's like a check off to say, yep, it's been completed. Again, this was given by an order, and purposeful rounding, for example, is an I did it on every shift. So through the day, it shows you here's the protocol when you click on the P to review kind of what that means. So if the patient is sleeping, do not wake unless guided by the patient plan of care. 8 checks, the purposeful rounding, the environmental, the pain, the personal care, position, pumps, possessions, the ask if there's anything, and when you're going to be back next. So it really covers your integrity of your click off. I'm just gonna minimize that a little bit. Oops, sorry about that. Okay, so I have looked at that, and let's say I was reviewing, it's just a simple click off. You click on when the time you did it, if you did it earlier, or you did it, or you're want to go back to a different day because you missed that, you can change the clocks up at the top. So I just document purposes around it. It says save documentation to the following interventions. I say save, and now you can see that that's done with a last done of 1 minute. If I refresh, that goes away, and now you're under your new time frame. Physical assessments is another good one to look at. Also, don't forget when each facility makes their own like standard of care, what they want in it, and their frequency. So you can see that there's routine, there's a one time, there's complete in the first hour, and then whether it's every day after that or every 7 days, you can see the difference in interventions. So when we go to physical assessments, I just want to show it's a bit of a varied efficiency. So for example, it's a head to toe. So you start with neurological. If your neurological assessment is within defined standards, which is always defined underneath your criteria. So in this case for neurological, within defined standards is alert and orientated to person, place, and time, and obeys simple commands, able to verbalize, understand, and moderately placed, able to move purposefully, behavior appropriate for the reason, for a mission, and et cetera, et cetera. So I want to stay within defined standards on my assessment. It automatically jumps you to your next assessment. If you had a significant finding, for example, it wouldn't do that. It leaves within the expected standards out, and you can go on and document your findings. So now, since I said within defined limits, I'm into the eyes, ears, nose, and throat assessment. Again, that's within defined limits. Respiratory assessment, I did find significant findings. She does have pneumonia, so I know she has a productive cough. Her respiratory depth is normal. Accessory muscles, no, but definitely some retraction. Regular respiratory pattern, chest wall shape is normal. My auscultation, so I heard coarse crackles on the bilateral lower lobe. You can also, let's say that these did not meet your criteria, they were previous documentation history locations, you could add another lung location. So you could, let's say you heard something in the right posterior lower lobe, hit OK, and now another instance field comes up, and you could change that. Let's say you heard a wheeze, expiratory wheeze. Air entry was a bit diminished as well, and your oxygen is sitting at 92. And this patient's currently on room air, and it's a productive cough. Again, you can continue on. If you didn't do the assessments, you can leave them blank. And I've done the appropriate assessment for the pneumonia. So as you can see, it is done. If I hit refresh, it drops off and my clock is gone because I have met the frequency criteria. I'm just noting that I have 15 minutes left. I just want to review a few more things. So if you go back to your home button, which is your status board, where I was, and I closed my hand off because I had reviewed it, you can see some of the orders that have come through. So right away, I can see that it's a low sodium diet. that there's an oxygen order if SATs are below 92. So I'm really going to watch that because I know she's hovering at 92 right now. Full resuscitation, she's in droplet isolation. We call these on the inpatient floor status boards. I know in emerge they call them trackers. They generally function in the same way, just different information based on their location and their needs. So let's say the patient's ready for discharge. The doctor has verbally told me that the discharge, this patient's ready for discharge. So I'm going to go into orders. I am going to enter a discharge order because Dr. Rogers has told me, and I'm helping her out with time because normally they do the whole, oops, sorry about that. They do the discharge with prescriptions and all that fun, but this one's going to be a simple one. So if there's any instructions, the physicians can enter it there. I'm going to submit. I have said the discharge order is a routine. I am submitting. So now I can go to the discharge tab. It looks similar to the emerge one, just with some different features. So reason for visits already there. Your discharge order has been placed. And if the physician did it, it would be pertinent to the time and date they did it. Any prescriptions required. So what it's saying right now is that there's this ordered for a home med and there's no action. So there must be a prescription already at the pharmacy. Any instructions you'd like to put in, any notes to the community pharmacist or pharmacy. And then here are your assessments. Your discharge planning assessment could be done by a discharge planner or the nurse or social worker, whoever is in your facility that does that. I have clicked off all those notes. I would like to do them all at once. So I'm going to click all three and hit the pencil button. That opens my piece. I can look at my past medical history. If I have to add something to the past medical history, I can do that here. Your discharge, mode of discharge, so wheelchair, spouse of partner, community services, we'll say respiratory care services. Yep, I've sent them to the community pharmacy and the primary care. Appointment referrals, follow up with family MD into the 4 weeks. Discharge information gave to patient and family member. I talked about appointments, we talked about meds, prescriptions, and supplies. Not an internal transfer, patient belongings returned, it was not applicable, and discharge planning discussion with patient and spouse. Details of barriers, none. Discharge needs, so they're going home. They're having respiratory services. Follow appointments, referral required, nope. Discharge arrangements, so if there's anything like home oxygen, we can talk about any other notes like waiting for, you know, such and such company to come to house. Departure transportation was given by family. And then again, if there's any transfer information. So I'm going to save and exit. I didn't do anything in the discharge planning, so it's just letting me know it'll be blank. So I've last documented on these things. Any standalone forms, print languages, referrals, and your patient disposition. So that's your dad's codes. This patient's going home with support. And again, when the patient leaves, you can always save until the patient gets the ride and goes home. When they're ready to leave, you hit today and now. You hit yes, confirming that that is the date and time you've chosen, and you save and close. So when you go back to your lists, they still stay on your My List after discharge. You can see the discharge has occurred. And on the unit list, it will automatically drop off. And My List stays up for I believe 2 weeks. So if you need to do any charting, and then obviously you remove the patient from your list. I will stop my sharing.
Would it be possible to show, so in a situation where you had a patient, like let's say they are being transferred in from a regional site to, you know, into Thunder Bay, and the doctor has sort of pre-written some admission orders. So when the patient gets here, do X, Y, and Z or something like that. Is that just a normal sort of order set? Does it go somewhere different? Is it possible to sort of show how you could order something ahead of time and have it sit there until the patient arrives?
So yes, there's a functionality called a hold queue. And so a hold queue can be placed on a patient at the MRN level. So it's above any site's accounts level. So let's say North Bay frequently gets pediatrics patients, right? Because a lot of smaller sites around us don't have pediatrics. So a physician could place a hold queue on a patient. Typically, we ask for a pre-account just because it's a little easier. And usually bed allocation knows the patient's coming, right? So that's generally what happens. I can share my screen and sort of show you the other functionality in. So what I did was I just put in test as my last name and I went looking or test it. I'm looking for a patient. So I'm just going to grab a patient. You can see these ones are discharged, but I'm going to grab this patient anyways. So typically we like it if the patient's been at your site before, but I as I said, you can put orders, even though this patient's discharged, I can create a hold queue for this patient. So in the order management section, I was on current and there is no orders, of course, because this patient's discharged. On enter, I could make new orders, but that would be on this discharged account. But in this little drop down, I have historical as well as the hold queue. Historical is how I can see orders that existed on this account. And I need to put in a date range for when that patient was there. But the hold queue is where I can add an event and I can create an event which will hold all of these orders. So a couple of functions we have for that. We do use it in preoperative. We are using it for direct admit. You can see the emergency room does have one. Acute pain services at some of the sites where the physicians like to put in orders for acute pain service if it's utilized. And then of course, post. Our bigger sites, we do have stem cell, as well as we have been using the hold queue as suggested orders for allies and consults. So they don't want to necessarily make those orders because they're not the MRP, but they want to suggest to them what they're going to use. So I'm going to use the direct admit as my function. And here I'm going to pick North Bay because that's where the patient's coming to. So I have to pick an order facility and that more or less will link my orders to that site's capabilities in the dictionaries. So I want to make sure that I'm ordering meds that exist at that particular site. And I'm going to put my event date for tomorrow. Okay. And then I go to add new, and this is where I can, again, just choose an admit set. I could choose separate orders. I could just type in by search word if I want. I'm going to use my general admit just for the ease of time here because I know that everybody needs to see. I'll talk about this as well. So this pop-up comes when I have a set that I've favorited and personalized. Which some sites do have that capability. And this is just notifying me that there's been edits to that main set. So I'm going to save that. Again, you can see pre-designated orders. I'm going to unselect these ones. I don't want to take a lot of time filling out all these mandatory fields because of our time for this meeting, not because I don't want to do it. So I can see that I have 15 orders. I've already pre-selected a lot of orders in this set. So I'm going to go ahead and submit that. And what it's going to do, it's going to show me my orders so I can see upon activate and some things that say upon activate and activate +1. So that's a series of blood work that I wanted. So I have a count of maybe 3. I didn't review that, but I'm going to guess that I put 3 because that's generally what I do. Now this hold queue sits on this patient. And what'll happen is the nursing staff can see the hold queue and they can activate it once the patient arrives. I, as a physician, could activate it and we can set it to future activate as well. Erin, if you want, I'll stop sharing if you want to grab Cord's test.
What happens to the orders if the patient never does show up?
So a hold queue will hold on the patient to the event date, and then 14 days post the event date, it disappears, it purges from the system. You can also, I'll add, just because Erin's taken some time to do her patient app. You can also add to that date. So I could change that date at any point and push it out. So during COVID, for example, we had a lot of pre-op hold queues that were set that we needed to push out the event date because surgeries were being canceled and rebooked. So at any point prior to the event date, you can change that event date and push it out further. One site that we do have is using the hold queue for oncology sets, and it's a very complex workflow where the whole queue is generated and then has subsets that are set so that nursing would be able to grab a febrile neutropenia when that happens for that stem cell patient, not necessarily if, but when, right? Yeah.
So I can see hold queue directly on my tracker by opening up the detail box. If I were to go place orders in on this patient, I do get a prompt that there is some sort of hold queue event. I can either go directly to orders and ignore this. If I go to hold queue, then I can view it. So we do use hold queue in the ED. So think of those like one-time returning antibiotics, or the patient's coming back the next morning to register in ED, but then go to ultrasound. We do have that capability of putting in some of those hold queue orders for the emergency department.
And one more question about the purging of orders. Does it also purge if the patient is discharged or there's another disposition like death, AMA?
Death, yes. AMA, no, because that patient, so as I said, it's held at the MRN level, not at facility level, right? So it's not at a site in specific. It's held above that. So essentially, a hold queue will display if my patient is supposed to come to North Bay but gets admitted to emerge in West Nipissing. That hold queue will prompt them that it exists. Now, it will not function for them. It just tells them that it does exist. They can't pull it down. It won't come down in orders because the orders are associated to North Bay.
Well, thank you very much. I know we're at time. Oh, one more question. Are we able to cancel a pre-in if orders are entered on the account?
It's Cat, but I believe it's no. The orders have to be removed first.
Absolutely. Any documentation and orders have to be removed first or moved to a different account if there was an in error.
Well, thank you all very much again for your time today. It's been a great week of demos, and I'm sure there's many more questions that our neck of the woods has for you guys, and I'm sure we'll see you again in the future. But I wanted to thank you very much for your time and your expertise. And for those of you in the Northwest, we are working on a way to share these demos. Hopefully we'll have a solution by the end of next week. We are able to share it through a WebEx link sort of individually. If you need it sooner, you can just email myself or your change specialist and let us know. We can get these to you, but we are working on a way to have them available through our website so they're more generally available to people. And thank you again. Have a wonderful rest of your day, everyone. Take care.
Thank you.
Thank you.